Good morning, good afternoon, or good evening. My name is Jim Freeman. I'm Senior Director for Global Assay Development at Siemens Healthcare Diagnostics. I'm responsible for immunoassays developed and marketed on the Advia Centaur family of systems. If you have questions, please write them down in the Q&A box located on your screen, and at the end of the presentation I'll be happy to answer a few questions given time. For many years now, you've seen media reports concerning the sunshine vitamin, or vitamin D. With this news comes a broad spectrum of clinical and analytical factors that can impact vitamin D results. Probably running vitamin D assays or testing patients with a vitamin D deficiency or insufficiency, and you'd like to know more about treatment, or you're doing research. So today we're going to talk about vitamin D deficiency and at-risk groups, reference ranges for vitamin D results, the variability in the results between immunoassays caused by vitamin D binding protein and the releasing of vitamin D from the binding protein. We'll talk a little bit about the 3-epimer of vitamin D3. We'll talk about the importance of a total vitamin D measurement, the standardization of vitamin D test results, which will lead into the Vitamin D Standardization Program, or VDSP, and what that's all about. And also, finally, the standardization of the Siemens assay for total vitamin D. Insufficiency and deficiency rates have increased, and as a result, there's an increased concern that our global population does not have adequate circulating levels of vitamin D. This is due both to increased knowledge concerning the optimum levels, what they are, and the lifestyle changes that have affected endogenous vitamin D production. Our society has moved from work and activities outdoors to jobs and activities that are predominantly indoors. Excuse me a second. Seasonal, geographical latitude, time of the day, cloud cover, smog, skin melanin content, and sunscreen are other factors that affect the UVB radiation exposure and vitamin D synthesis. While sunscreen has reduced the incidence of skin cancer, it's also reduced the vitamin D production by about 95%. The decreased effective exposure to sunlight is the most important reason for a marked increase in vitamin D deficiency. We also do not get enough vitamin D in our diets. Milk is fortified with vitamin D. However, the amount of it that we drink has decreased since the 1960s. Other foods that are high in vitamin D are fish, especially salmon, mackerel, and tuna. Mushrooms also have a very high vitamin D content. So dietary sources, though, are not enough to offset the lack of direct sunlight. There are several high-risk groups for vitamin D deficiency. Those include infants. Mother's milk contains approximately 25 IUs per liter, but often the mother is deficient in vitamin D as well. Therefore, infants are prescribed 400 IUs of vitamin D daily. Older adults have reduced 7-deoxycortisol, so they cannot synthesize vitamin D as well as younger adults. Also, their kidneys are less able to produce the active hormone 1,25-dihydroxyvitamin D. Obese individuals are at risk for vitamin D deficiency due to the fact that vitamin D is solubilized in fat and is therefore not able to be transported through the body. And also, dark-skinned individuals are at risk for vitamin D deficiency due to melanin content in darker-skinned people, which absorbs the sunlight, therefore not allowing the UVB to be absorbed. There we are. So there's considerable discussion of serum concentrations of 25-hydroxyvitamin D associated with deficiency and sufficiency for normal bone health as well as optimum overall health for individuals. So as you can see here, deficiency is defined as less than 20 nanograms per mil. Insufficiency is 20 to 30 nanograms per mil, and sufficiency is greater than 30 nanograms per mil of total vitamin D. Although the Institute of Medicine report provides guidance for dietary standards for the general public, which will be used by government agencies to set dietary regulations, the Endocrine Society recommendations are intended for use by clinicians with patients who are at risk for deficiency. So you'll see here that the Institute of Medicine and the Endocrine Society do have different cutoffs depending upon the application for which they're determined. There are two major forms of vitamin D. There's vitamin D2, which is synthesized by plants and not produced by the human body. And there's vitamin D3, which is made in large quantities when sunlight strikes the bare skin. It can also be ingested from animal sources. Seasonal changes, geographic latitude, time of day, and cloud cover, and the use of sunscreen are among the factors that affect the UVB radiation exposure and vitamin D synthesis. The sunlight from November to February above the 42 degrees of latitude produces insufficient levels of UVB for successful synthesis of 25-hydroxyvitamin D. UVB radiation penetrates unprotected skin and converts cutaneous 7-hydroxycortisol to pre-vitamin D3, which then isomerases to vitamin D3. The other source of vitamin D is in our diets. When we ingest vitamin D, it's absorbed by the intestine. Once in the bloodstream, vitamin D is bound to vitamin D binding protein or albumin and carried to the liver. There in the liver, the vitamin D is hydroxylated to the 25-hydroxy form of vitamin D. Then the kidney produces another hydroxylation step, which produces the 1,25-dihydroxy vitamin D, which is the main vitamin D. It's the major steroid that's involved in mineral homeostasis. Vitamin D is involved in a very complex hormonal control. When serum levels of calcium dip below 8.8 mg per dl, it prompts the proportional increase in the secretion of the PTH. The PTH signals the kidneys to increase the production of 1,25-dihydroxyvitamin D by increasing the production of 25-hydroxy-1-alpha hydroxylase. The increase in the 1,25-dihydroxyvitamin D stimulates the increased absorption of calcium in the intestine and upregulates the genes in the bone to stimulate bone remodeling. An expert panel in 2010 was put together to determine vitamin D guidelines. They reported that patient values should be a single total 25-hydroxyvitamin D measurement in nanograms per mil. The assay should measure both vitamin D2 and vitamin D3 with equimolarity. Serum would be the recommended sample type for vitamin D testing. And we should also report health-based reference intervals. In this quote, Finney et al. Accurately state that total vitamin D must include the contribution of both vitamin D2 and vitamin D3 to get the best result to assess the patient's condition, either being deficient, insufficient, or sufficient for vitamin D. These 25 experts divided the clinical applications of vitamin D testing into two groups. Classical applications for which the level of evidence is very high with numerous randomized controlled studies, and then some of the non-classical applications for which long-term studies still need to be done, and they are being done, but the amount of evidence is increasing with the introduction of additional studies. So for the classical applications, we have individuals who are at risk or have osteoporosis. elderly patients with a recent fall, pregnant women, patients with chronic kidney disease, transplant patients, obese individuals, etc. Some of the non-classical clinical applications are in the area of cardiology, autoimmunity, and oncology. So for years, we've monitored vitamin D to help determine our bone health. In the 1930s, bone health was improved dramatically by fortifying milk products with vitamin D. This has all but rid the USA of rickets. Fortified milk is a major source of dietary vitamin D in some countries. The use of vitamin D is very important in treating bone disease, mostly predominantly in osteoporosis in elderly female patients. There have been numerous studies showing a statistical link between vitamin D deficiency and other diseases. These include cardiovascular disease, various cancers, diabetes, glucose intolerance, multiple sclerosis, and autoimmune disease. These statistical relationships are the reason that many physicians believe that vitamin D is a good general health marker. In non-skeletal disorders, the benefit of vitamin D as a treatment is still being explored. So the consensus panel has made recommendations for maintaining optimum vitamin D levels. 25 hydroxyvitamin D should be greater than 30 nanograms per mil for patients who are at risk for skeletal malformalities, cardiovascular disease, autoimmune disease, and cancer. They've also determined that we should supplement first and then test individuals with little sun exposure or dark skin. The interval, the testing should happen after the individuals have been supplemented is approximately 3 months. The upper level of safety for vitamin D is 100 nanograms per mil. A maintenance dose of 800 IUs per mil per day should be given, and we should be reporting the total 25 hydroxyvitamin D. So the Endocrine Society has come up with clinical practice guidelines for the evaluation, treatment, and the prevention of vitamin D deficiency. So infants and children who are at risk should be taking 400 IUs per day of vitamin D. Pediatric patients should have a dose of 600 IUs per day. Adults, 600 IUs per day. Age 70 plus, 800, and pregnant and lactating women, 600 IUs of vitamin D per day. If they're not getting that from their diet, they should be supplemented. So let's look at some variability among vitamin D assays that are currently being used. Here we have 6 immunoassays and 1 HPLC and an LC mass spec. So the DQuas survey scheme is a survey scheme that 5 unique patient samples or patient sample pools of serum are distributed to laboratories that are reporting vitamin D measurements. And those measurements are then reported back to DQuas, and then a report is given at the end of each quarter for the performance of that particular laboratory's vitamin D results. And as you can see here, the immunoassays, so this graph represents the mean value of immunoassays A through 6 being used all over the world in hundreds of laboratories. The HPLC is used in a handful of laboratories around the world, and you can see the mean value with the HPLC as well as the IDLC mass spec value. So this demonstrates the need for a standardization for vitamin D testing due to the variability of different assay manufacturers and different IDLC mass spec laboratories reporting vitamin D measurements. This was from the January 2013 DQuas survey material. So there are several factors that contribute to the variability among different manufacturers and different laboratories. The most prevalent or the most predominant reason why vitamin D is variable in measurements is the historical lack of an international vitamin D standard. There is a NIST material that is a concentrated form of vitamin D that can be spiked into human serum and used as a standard. However, that material may not be commutable between immunoassays. Releasing vitamin D from the vitamin D binding protein is essentially important, and different manufacturers, especially with immunoassays, have different releasing agents to release the vitamin D from its binding protein, and so you'll be getting less or more released, which would cause differences between manufacturers' results. Also, it's very important that we detect with equimolarity vitamin D2 and vitamin D3. The use of some polyclonal antibodies in some immunoassays do not detect D2 and D3 with equimolarity. Heterophilic antibodies are always a problem for immunoassays, so if the requisite blockers are not added to the reagent formulations, this will impact vitamin D measurements as well. And before a standardization program was implemented, each manufacturer had a different way or a different method by which they standardized their immunoassays. There was not a common methodology on how to standardize the vitamin D measurements from one manufacturer to another. So a little bit more about vitamin D and how it's bound to the binding protein. Vitamin D is embedded in a hydrophobic groove in the vitamin D binding protein. Two water molecules in that groove aid in the binding of the 25-hydroxy vitamin D and its metabolites into the binding protein. The vitamin D binding protein binds vitamin D3 with a greater affinity, approximately 5 times greater affinity than the vitamin D2. And so therefore, not only do you need a monoclonal antibody that can detect vitamin D2 and vitamin D3 equimolarity, a releasing method must be developed that will release the vitamin D2 and vitamin D3 from the binding protein with equimolarity as well. A little bit more about the releasing reagents of vitamin D from its binding protein. Since it's very hydrophobic and binds to the binding protein very well, this can be very challenging. For some RIA methods and most LC mass spec methods, an extraction step using organic solvents is used. This precipitates the protein within the sample, releasing the vitamin D to the organic layer, essentially releasing all the vitamin D from its binding protein in the sample. An automated immunoassay, on the other hand, is not compatible with organic solvents. Therefore, other methods must be used to release vitamin D from its binding protein. And for immunoassays, the releasing agents and the releasing procedures that are done are all proprietary to that manufacturer. So a little bit about the 3-epimer of vitamin D3. The 3-epimer of D3 is an optical isomer of 25-hydroxy vitamin D3. This optical isomer is of clinical interest because it can cause interferences in some assays that quantify 25-hydroxy vitamin D3. If IDLC mass specs are not run properly to be able to resolve the 3-epi form of vitamin D from D3, you'll get an over-quantitation of the vitamin D3 in the sample thus causing an overquantitation of the total vitamin D that's reported for the patient sample. The 3-epimer is not in very high concentrations in normal human serum, but there are some disease states that cause an overproduction of the 3-epi form of vitamin D3. That's the optical isomer in the cartoon. So again, the failure to separate the 3-epimer can cause an overestimation of the total vitamin D3 in the human serum sample. Overestimating by mass spec that do not differentiate them, as I said a few minutes ago. So it's very important that we detect both forms of 25-hydroxy vitamin D, both D2 and D3. Assays should recognize, the antibody should be able to detect D2 and D3 with equimolarity for best performance. And underreporting vitamin D2, if the antibodies do not cross-react 100% to vitamin D2 or very close to 100%, can result in oversupplementation with vitamin D and potentially cause vitamin D toxicity. So the Vitamin D Standardization Program, or VDSP, had a few primary objectives. The VDSP is a collaboration between the NIH Office of Dietary Supplements, NIST, the CDC, and Ghent University. It's to promote the standardization of laboratory measurements of vitamin D. Now, how are they going to do this? First of all, an appropriate standard must be commutable, not only within different immunoassays, but also from immunoassay to LC mass spec. So with the VDSP, what this group did was they obtained 50 unique serum samples, and in order to be commutable among immunoassays. So the first thing that they had to do with these 50 samples is determine by a reference measurement procedure, or RMP, the value, the analytical value of total 25-hydroxy vitamin D2 and vitamin D3. This RMP was developed by both NIST and Ghent University at Dr. Linda Tienpont's lab. These 50 unique samples were measured at both laboratories, at NIST and at the University of Ghent. These samples were made available to manufacturers of vitamin D assays, as well as LC mass spec laboratories reporting vitamin D measurements. These 50 samples were then to be used as a standard. Now, these 50 samples ranged in measurement of vitamin D from 5 nanograms per mil to approximately 100 nanograms per mil. These individual samples collectively would then be used to standardize a manufacturer's immunoassay or an LC mass spec laboratory for vitamin D measurement. There are 2 publications listed here that describe the VDSP program. So the VDSP is very important because historically there's been a lack of standardization across manufacturers and different methods. So the vitamin D standardization program will improve the harmonization of test results for vitamin D. That is the goal. So a couple of questions about the vitamin D standardization program. What's a standardized laboratory measurement of 25-hydroxy vitamin D? One that is accurate and comparable to the NIST and Ghent reference measurement procedure over time, location, and laboratory procedure. Second question, what are the NIST and Ghent RMPs? The 2 methods are aligned. They're IDLC mass spec systems and extraction procedures that are aligned, and they are anchored to the NIST SRM 2972, which is a concentrated form of vitamin D3 with a quantitative value associated with it. These RMPs are used to align gold standard measurements to survey materials. So the DQuas survey materials and the CAP survey materials are now reporting bias to the RMP, not to the all method trimmed mean as previously done. So what is the impact on clinical assessment with respect to the VDSP? This standardization will improve the harmonization across manufacturers and methodologies. It will also improve the confidence that physicians have in the accuracy of test results for vitamin D, be it done on one immunoassay or a different immunoassay. The vitamin D levels should be the same. This is just one example of a very successful standardization program, the Standardization National Glycated Hemoglobin Standardization Program, or NGSP, for the measurement of hemoglobin A1C. In 1996, there were about seven assays for hemoglobin A1C, and the NGSP put out a survey material, one sample. And that sample showed a very diverse, very different measurements with a very high CV. So there was a need to standardize hemoglobin A1C. And over the years, as you can see, even though the increase in different methods to measure hemoglobin A1C have been introduced into the marketplace, the variation between measurements and even within manufacturer has been greatly reduced. So this is just one example of a very successful standardization program. The CDC has implemented a certification program for vitamin D testing. So the CDC certification program, it's a two-phase approach. In phase one, 40 samples are made available to manufacturers of vitamin D methods as well as LC mass spec laboratories throughout the world. These 40 samples have values for the RMP associated with them. They are used by the manufacturers to determine whether or not their immunoassay is standardized to the RMP. And if it's not, then they can use these 40 samples in addition to the 50 samples from the VDSP program to standardize their methods. Phase two is a monitoring program where every quarter over 1 year, 10 samples are sent blind to participating laboratories and participating manufacturers. The test results on these samples are then sent back to the CDC, and a measurement of bias and mean CV is determined by the CDC when they get the testing results. Each one of these phases, as I said, consists of 10 samples. They're tested by the manufacturer in duplicate over 2 days with a single lot of reagent. In order to be CDC certified, the mean overall bias needs to be less than 5% from the target RMP value, and the mean CV must be less than 10% in order to gain CDC certification. So the CDC is monitoring, or has set up a program to monitor the standardization of vitamin D immunoassays as well as LC mass spec laboratories in conjunction with the VDSP program. It's something very similar that they've done with estradiol and testosterone in the past. So the goal here with the CDC certification program is to improve diagnosis and treatment and prevention of diseases by standardizing clinical laboratory measurements. So we will create a measurement result that are traceable to one accuracy bias. So a little bit about the Siemens Adviacentar vitamin D total assay. The Siemens assay was introduced under a standardization that we had performed in-house. Since the introduction of the Siemens method, the vitamin D standardization program made available to us the 50 samples with RMP values. We had used those samples along with other samples that we have obtained that have RMP values associated with them, and we have re-standardized our assay to the RMP. What this means is that we have an internal set of gold standard materials that we prepare in-house. These materials are value assigned directly from the 90 samples that we obtained from both the CDC as well as the VDSP. So our assay is standardized directly to RMP standard materials. Again, we've modified the assay standardization. Now, the assay itself, the reagents that are in the ready pack, the releasing reagent, the antibody, the particles that are used in the assay have not changed since the introduction of the method. What has changed is the way that the assay is calibrated. The calibrator values have changed because the standardization is now linked to the RMP. So again, assay standards are manufactured whose values are tied directly to the RMP. These standard materials are used to value assign calibrator material as well as control material and master curve materials as well, the MCMs. This graph here demonstrates the Adviacentar method test results on the y-axis versus RMP values on 177 samples that we've been able to obtain. The slope and intercept and the regression coefficient are very good. So as you can see that the assay gives accurate test results to the RMP from values of approximately 5 nanograms per mil up to 100 nanograms per mil. That's the highest endogenous level of vitamin D that we were able to obtain with RMP values. So this demonstrates the alignment of this particular immunoassay against the RMP with 177 samples. As I mentioned before, the assay was introduced under a standardization that we developed internally. This is a comparison of the two different standardizations for vitamin D, the original standardization, and then also the standardization to the RMP on the y-axis, and then on the x-axis we have the deosorin liaison values. And as you can see, the slope with the without RMP alignment is 1.02, and the intercept is negative 0.17. It agrees fairly well with the deosorin liaison. The slope and intercept, once alignment has been done with the RMP on these specimens, is 0.93 and an intercept of 1.22. So you can see that the Centaur method, we only had to change the our standardization, and that's represented here. So we changed our standardization from our original standardization to now the RMP alignment. This is a comparison of samples run on the Adviacentar and then quantitated with the two different standardizations. So the current, the original standardization is on the x-axis and the VDSP standardization is on the y-axis. And as you can see, between about values of 20 to 50 nanograms per mil, the values are very similar between the different standardizations, whereas lower than 20 nanograms per mil, the values with the RMP tend to be lower, and greater than 50 nanograms per mil, the values again tend to be lower when referenced against the original standardization for the method. This is a method comparison from France against the DSON liaison. This is the RMP standardized method for the Advia Centaur has been released outside of the United States. We are waiting FDA approval for the RMP standardized method to be then marketed within the United States. This is a correlation between, done in France, between the liaison platform and the RMP method. And as you can see, the slope is 0.92 and the intercept is 5 nanograms per mil. This is very much in alignment with the correlation I showed you a few minutes ago between the RMP method and the DSON liaison. In addition, there was a method comparison done in the UK. This is the Advia Centaur original standardization on the x-axis versus the RMP standardization of the Advia Centaur on the y-axis. And as you can see here, values less than 20 nanograms per mil read a little bit lower on the RMP standardization versus the original standardization for the method. This is the DQuAS October 13th distribution in nanograms per mil. Again, 5 samples. Samples 441 to 445 with 6 different immunoassays. The NIST. Now this shows what the RMP value assignment of the material is. That's the orange bar, which is the third from the left, third from the right for each sample. And you can see how it aligns with the different immunoassays, as well as the IDLC mass spec. So there is still some disagreement between immunoassay manufacturers because not all manufacturers have been able to standardize to VDSP if they choose to do so. The Siemens method, we chose to standardize to the vitamin D standardization program. And our results are in good alignment with the NIST value or the RMP value for these 5 samples. So from January through October, there have been several DQuAS surveys that have gone out. This slide represents the all laboratory trimmed mean, or ALTM. It also has the Siemens value on the original standardization. We also show the Siemens value once the assay has been aligned to the RMP. The overall LC mass spec average for all the results reported back to DQuAS using LC mass spec. And I would like to mention here that even though a laboratory is running an LC mass spec, it does not mean that that assay, that LC mass spec is linked to the RMP. It's all determined by what is being used as the internal standard, the quantitative value for that internal standard. Different LC mass spec laboratories release vitamin D from the binding protein using different organic solvents. They have different internal reference materials. LC mass spec laboratories can differ as much as immunoassays can differ. It all depends upon how the method is standardized, be it LC mass spec or immunoassay. But it's very important that we standardize methods to patient samples. The patient samples allow for the commutability between different immunoassays as well as to IDLC mass spec. College of American Pathologists, or CAP, had a vitamin D survey panel that they send out about twice a year. It consists of 3 to 5 samples. Here for 2013, there were 2 CAP surveys that were sent out. Survey A and Survey B. These are the testing results from the final CAPS survey. And as you can see here, the target value is the RMP value. And we have different manufacturers of immunoassays as well as IDL CMS spec. And the Siemens method here, the Siemens values are from the RMP. All survey materials pass the Siemens method. The range is plus or minus 25%. That establishes the range that the results must fall in to be CAP accredited for vitamin D testing. This is just graphically representing those results from CAP Survey A of 2013 for the different manufacturers on the previous page. These are the results from the ABVD Panel B from 2013, shown graphically. So, Siemens participated in the CDC vitamin D standardization program, as I mentioned earlier. I'm sorry, it's certification program, as I mentioned a few minutes ago. These are the test results from the four sets of 10 samples that were sent to us over the course of the last year. Again, the acceptance criteria is the mean bias must be plus or minus 5%. The mean imprecision must be less than 10%. Results are reported back to the CDC, run over 2 days in duplicate testing per run, 2 runs, 1 run per day, duplicate measurements per run. And here we have the Siemens return value on the 40 samples as well as the target value for each one of the distributions that were sent out. The overall mean bias was 0.3% and the mean CV was 5.5% for the results reported back to the CDC. This is the correlation presented graphically with the IDL CMS spec RMP target value and then the Siemens return value. Slope is 1.01, intercept of negative 0.42, and an R value of 0.95. So again, this is very similar to the 177 samples that I presented earlier in the presentation with RMP values compared to the Siemens method. So in summary, the publication of the VDSP test results enables laboratories to know which manufacturers and methodologies are considered certified, but using certified procedures. Centaur method has a mean bias of 0.3% and the overall mean precision of 5.5%. This certification demonstrates that Siemens is in alignment with the RMP, an approved RMP that was used for the VDSP program. So in summary, many factors influence the measurement of vitamin D by immunoassay. Vitamin D binding proteins, the 3 epimer of vitamin D3, the ability of an immunoassay to detect equimolarity, both D2 and D3, and of course, assay standardization. This standardization program, the VDSP, along with the CDC certification program, will improve the harmonization across manufacturers and different methodologies, providing confidence in the accuracy and test results for vitamin D. And once again, Siemens has re-standardized our method to be in alignment with the gold standard. That's the end of my presentation. I will take some questions now. Bear with me, and I can read through some of them. This is a question So this question is, what is your opinion or thoughts or analytical challenges about the recently introduced vitamin D assay on a chemistry analyzer by Diazyme? I just saw this not too long ago, and it uses a very similar technology as an emit technology. I have not tested this in my laboratory yet on a clinical chemistry analyzer. It's all going to come down to the ability of the polyclonal antibody used in that to equimolar measure vitamin D2 and D3. In addition, the emit technology does have limitations on sensitivity. So I would be wondering how the analytical sensitivity was measured by that immunoassay. It does propose a challenge, running a homogeneous test for vitamin D, but I've not used that method in my laboratory. I don't have any other questions at this point in time. Please feel free to answer any questions that you would like. Well, here's a question. This is by Ms. Diaz from the Calgary Laboratory Services. Would the cost per test to be comparable with MSMS technology? It's a good question. I don't, for an IDLC mass spec, you have a significant cost for the instrumentation. Since it's predominantly a lab-developed test where you need to develop the methodology used in your laboratory using organic solvents, and then of course the liquid chromatography and the mass spec. We don't have an LC mass spec. I have one in our laboratory, but I don't know how much it would cost for an LC mass spec measurement. So it would probably be comparable to an LC mass spec measurement once you consider the cost of the equipment and also the highly trained operator that would be required to run an LC mass spec. A laboratory technician running a Centaur, it's a completely fully automated platform. So that particular immunoassay does not require the skill level that one would need in operating an LC mass spec. So depending upon the salary of the person running the instrument, the cost of the instrument itself, how many tests per day are being run by that LC mass spec laboratory. LC mass specs, the throughput of an LC mass spec is quite reduced compared to an ADVIA Centaur. The Centaur and other automated immunoassays, but Centaur specifically can turn around about 240 tests on vitamin D per hour, where an LC mass spec at best can do maybe one result. One LC mass spec can do maybe one result every 5 minutes. I've heard as fast as 2 to 3 minutes. However, the accuracy and the precision of that measurement being run so quickly would be in question. And again, when the columns are run quickly, the ability to resolve the 3 epimer is in question. So you might be getting some overestimation if you're measuring the 3 epi form of vitamin D. So, at best you're looking at a 5-minute per test result turnaround, whereas on Centaur you have about 240 tests per hour. So depending upon how many tests are done in the laboratory, cost of the equipment, et cetera, all those have to be taken into consideration. Okay, if there are no more questions, I'll thank you for your time and have a nice conference.